So will you define for us perimenopause and menopause?
Menopause medically is 1 year after the final natural menstrual period. Perimenopause begins when we reach a critical egg threshold level where the usual signals that actually come from the brain stop working on the ovaries as well. And we end up in the 7 to 10 year zone of chaos, really. No one sat down and said, hey, all of this is going to be affected. All of these organs are going to be affected. She's going to have, symptoms you are going to struggle to recognize as part of her perimenopause or menopause.
When I was in training, we were not prescribing hormones for menopause. There was a big study that came out that really made everybody very fearful.
Hormone therapy is not only not harmful, it will prolong her health span.
Welcome back to the As a Woman podcast. I'm Dr. Natalie Crawford, and today we're tackling one of the most misunderstood and most important chapters in hormone health, perimenopause and menopause. Joining me is Dr. Mary Claire Haver, a board-certified OBGYN, author of the New York Times bestseller, The New Menopause, and fierce advocate for changing the conversation around women's health. She's helped millions of women feel seen and supported during midlife, not just by explaining the science, but by validating their experience. And in this episode, we're diving into what really happens to your body, what symptoms like mood swings, weight gain, brain fog, fatigue are hormone-driven, and how to approach this transition with clarity, strategy, and self-compassion. So whether you're in your 30s or 40s or just want to be better prepared, this conversation will give you the language, tools, and support that you need to navigate the stuff with confidence. Let's get started.
All right.
Mary Claire Haver, thank you so much for joining me.
Thanks for having me.
We've been long friends, and I'm really excited to meet you in person and have you here. And I often talk a lot about perimenopause in my clinic, but we don't call it by that word. We say diminished ovarian reserve, because I'm seeing women trying to get pregnant. And what we know is that we're born with all the eggs we're ever going to have. We start to run out of them over time. And as we start to get into those lower egg count, we start to see hormone changes that show up in real life.
Yeah.
So will you define for us perimenopause and menopause?
So menopause medically is, but I'm educating others who don't realize it, is only 1 day in our life. And medically, we define it as 1 year after the final natural menstrual period. And what it represents, though, is something much, much bigger than the end of your periods. So like you were saying, we're born with our entire egg supply. And for most of our normal reproductive life, we have a very predictable rise and fall of our hormones from month to month throughout the monthly cycle. Perimenopause begins when we reach a critical egg threshold level where the usual signals that actually come from the brain stop working on the ovaries as well, and the ovaries become resistant just due to loss of ovarian function. And we end up in the 7 to 10 year zone of chaos, really, of hormonal chaos as you just go from your 3% of egg supply down to 0.
What I think is so interesting and most people don't realize is that there are so many different shifts in your hormones that occur before you start having the period changes.
Right.
And we see actually a predictable change in your period if you're looking, meaning you might get a short follicular phase or luteal phase, but you're still having regular cycles. They just seem a little off. And then they start to lengthen a little. Maybe you're still having them, so you're not thinking that this might be the cause of everything you're actually going through. But really, I would say the body's like a toddler. It wants a regular, predictable schedule. And when it comes to your hormones, that's the case. And when the ovaries get stubborn, like you said, this zone of chaos that starts happening because we no longer have this regular, predictable rise and fall of our hormone pattern. Low estrogen really becomes one of the biggest players when it comes to women's health. Is that right?
When we look at cardiovascular health, when we look at mental health, when we look at cognitive health, when we look, just about every organ system is affected and tends to work better with normal, predictable estrogen cycles. And when those shift and then go away in postmenopause, our bodies take a hit and we're just not as healthy.
Well, most people don't know this. You and I do, that there's estrogen receptors throughout our entire body.
Natalie, I know that now. I don't think I was taught that.
I don't think I know I wasn't taught that. I loved my residency at Parkland.
Yeah.
I delivered a ton of babies. I became a very confident physician, and I had no idea that there were estrogen receptors throughout our body.
I remember seeing the paper, looking at the G-coupled estrogen receptors, and all of the organs that they were located in. And I'm like, wait, no one sat me down in my 4-year curriculum of obstetrics and gynecology and showed me the location of all of the estrogen receptors, like the endothelium, like the brain. Like I intuitively knew it, but no one sat down and said, hey, all of this is going to be affected. All of these organs are going to be affected. She's going to have, symptoms you are going to struggle to recognize as part of her perimenopause or menopause.
I think it's important for the audience to know, because when I was in training, we were not prescribing hormones for menopause. There was a big study that came out that really made everybody very fearful. How do you break this down as far as helping somebody understand why there's a whole generation of women who've been told not to be on hormone therapy?
So I graduated from my training, so I'm a generation ahead of you, in 2002. So for most of my residency, we were prescribing hormones if someone had severe symptoms, Also, we were having lectures, I remember, of cardiologists coming in and telling us estrogen looks like it's really protective of the heart, and we think that you should recommend it for prevention of cardiovascular disease. And I was like, okay. And, family medicine was doing it, internal medicine was recommending it. And then, so the NIH decided to have a study. They had a new female head of the NIH. It was very exciting. And she said, hey, we know from observational studies that estrogen appears to be cardioprotective in the form of hormone replacement therapy. But is it just because these women are healthier and wealthier? Is this an artifact of the women who tend to get hormone therapy just have a better baseline, right? Or is this really happening? Totally reasonable study. And our outcome is going to be heart disease. Okay, so heart disease usually doesn't develop in women until their 60s, 70s, 80s. So starting the study, the average age of the women in the Women's Health Initiative study was 63.
Past the average age of menopause.
Much older than the average age of menopause. And so, okay, we're going to start the patients older. We did have some younger patients in the study, but we had patients up to the age of 79.
So crazy.
In the study, starting hormone therapy to see what the outcomes were. And the whole point of it was, is it going to prevent a heart attack? Is it going to be protective against cardiovascular disease? So they enroll, I think, 27,000 women in the study. They had 2 arms. For people who had uteruses, they got estrogen plus the progestogen or a placebo. And then for people without uteruses, they got estrogen only, because we know we need to protect the endothelium, the lining inside of the uterus, with the progestin, which we were always taught, right? To keep her from developing hyperplasia or malignancy. So everything looks reasonable. Let's run this study. They start collecting data, and I think we're around year 2 or 3. Here's where it gets kind of sketchy. And I've read multiple reports about this. A handful of the investigators, remember, this was the $1 billion study. This was huge. Multiple programs were involved. It wasn't just
multiple sites.
Multiple sites. So a handful, 2 or 3 of the lead investigators get together and say, hey, we're going to have a press conference before it was even published. And from what I understand, they got all of the investigators in a room, threw the paper out at them and said, make your changes. And they had no idea this was coming. It was basically saying that estrogen caused breast cancer.
And just like, boom, here we go.
And that there was no benefit to hormone therapy for the prevention of cardiovascular disease. And we have always known that estrogen can increase the risk of stroke. That was nothing new. So they call a press conference. They don't take any of the changes that the other authors recommended. And they have, announced to the world that this study is showing that estrogen is increasing the risk of breast cancer. So when you look at observational data, when you look at, the way they presented the data, you have relative risk and you have absolute risk. And most people, and I struggle with it myself, it's a little bit hard to understand the difference of population risk,
versus
a relative risk versus an individual risk. So when you look at what is the baseline risk of someone getting breast cancer, and then how much did we increase that risk from an individual? It was 1 out of 1,000 women per year. 1. But when you look at the relative risk, so the risk of getting hit by an asteroid, if you double that, it's still almost nothing. Right. And so
still exceedingly rare to get hit by an asteroid.
Right. But if you, decide to drive a red car, you might double that risk. And so explaining relative risk versus observation. So the relative risk went up about 25%. So here's the headlines.
Yeah. 25% increase in
risk
breast cancer.
of breast cancer. And that's what we heard. I was a chief resident. That's what I was on the cover of every major newspaper, every morning show, the nightly news. It was the #1 medical news story of 2002. Instantly, we think maybe 40% of women were on hormone therapy at the time, threw it in the trash.
Just stopped it.
Stopped it. We're down last year at Menopause Society. At the meeting, they presented that we were at 4% of women who were eligible were utilizing hormone therapy.
I'm shocked.
That's how low it had gotten. So the whole next generation of clinicians coming out of training programs, hormone therapy is dangerous. The risks are going to outweigh the benefit. But yet, in the ensuing 23 years, multiple parts of that study have been walked back.
Right.
Including the risk and safety data. When they stratified the risk.
Start looking at different groups alone.
Right. They look at age. Well, women who started hormone therapy within the first 10 years or before the age of 60 actually did show a 50% year-by-year reduction in cardiovascular disease. In the first 5 to 7 years, depending on the arm, there was no increased risk of breast cancer. The risk was so very low. Yet the taint of the fear-mongering around the risk of breast cancer
made estrogen the villain in women's health.
And in the estrogen-only arm, we saw a 30% decrease relative risk of breast cancer. It was the estrogen plus progestogen arm. And then another nuance was that the placebo arm in that group had an artificially low risk of breast cancer compared to the normal population risk of breast cancer.
Lower than the average population risk.
Right.
So of course
when
the
you
difference.
stack all of that together, even if you believe the data, worst case scenario, it did not affect the risk of cardiovascular disease. And so saying that a woman can't have hormone therapy if she has hypertension or any risk for cardiovascular disease or diabetes, just became a mistake. So what's the outcome of this? We have an epidemic of heart disease.
Yes.
We have an epidemic of frailty and osteoporosis, and we have an epidemic of dementia.
Right. And fear. Because I even see patients who will go into premature ovarian failure. They come to me because they're trying to get pregnant. They don't have a period. We start working it up. And I'm having this conversation with these very young women that you need to start estrogen therapy. It's going to change your life. I start listing off all the symptoms. And they're like, yes, 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 yes. But they are so afraid.
Terrified.
They're terrified to start estrogen because it's now just been this lore of how bad it's going to be for you to be on hormones, which I find so interesting because on this other end of the coin, there are people prescribing all kinds of hormones in different ways for different things and calling it weird, right? Here's the pellets of this, the compounded of that.
Here's where we've ended up. We have a generation of clinicians, you and I included, who are terrified to prescribe it, want to do what's right for their patients, have not been taught. And then we have snake oil on the far right.
Right.
And there's so few of us in the middle. That I think is trying to help the patient, but it's like, where's the evidence? Where's the safest way to prescribe this?
And women are getting dismissed.
Totally.
So they're turning away from traditional medicine because they're getting told the pat on the back.
They're seeing 6, 7, 8 clinicians on average before their menopause is even diagnosed.
That's wild.
I was sitting at my first Swell conference. So Swell is an organization that does a lot of education around female health. And so they had invited me to speak about nutrition. This is back in the Galveston Diet days. Nutrition and menopause. So I sat on a panel with like 5 other women. It was a cardiologist, me, a psychiatrist. It was a super fun panel. But one of the major talks that day was Avram Blooming, Carol Tavris, and Sharon Malone talking about the Women's Health Initiative and how all the findings have been walked back. They presented the statistics. They basically gave an overview of estrogen matters. And I sat in the audience. This is before I became a menopause specialist. And I cried my eyes out.
Like you felt seen as a woman.
I didn't know. I was furious. This was tears of rage. How could I not know this? How could I have gone through 23 years of CME, board certification, and no one had pointed this out to me? All those years I had dismissed patients. I was a terrible menopause provider. I didn't think so. But how had all the CME that ACOG had put in front of me
every year you
not
do it
included this vital, important information that for the vast majority of women, hormone therapy is not only not harmful, it will prolong her health span.
Lifespan, longevity.
And that was my lightning bolt moment. That was the lightning rod that catapulted me of, I have a big mouth. I have a social media following. I'm not going to stop talking about this.
You have a platform. You have a mission. I'm so honored to have you here and proud of everything you've done, because when you start talking on the internet and in public places about something that's controversial, I know this myself, people start to have a lot of things to say about it, just because they're threatened by it or because they see what you're saying and maybe some aspect of it they feel like they're not doing or they feel called out by. And I know that it hasn't always been an easy journey for you online, even from the medical community, which is wild to me when we think about it, because our common goal should be to help women live a better life.
Really the biggest pushback have been certain aspects of other menopause providers or other people who were big in the menopause space who I think they just felt threatened because they were kind of doing a great job spreading the message, spreading awareness, and then there's new people coming up behind them, and I can't pretend to know what's going on in their head, but I'll tell you what's happening now. I'm getting invited to go and speak at medical schools, residents. I just yesterday spoke to a room full of family practice residents, in Pennsylvania via Zoom.
Yeah.
But
the tides are changing.
The tides are changing. These massive healthcare systems are flying me in to go and speak to their providers by the hundreds at these big conferences.
I love it.
And they are so appreciative. They are like, I see them in tears. I see them having their light bulb moments. And I'm like, this is how we make change. Medical societies are great, but it is very much an ivory tower, and they're struggling to get the message out. And I will speak in front of any clinician who will listen to me about the importance of women's health after reproduction ends.
And you're helping on both ends. You're helping patients become better advocates for yourself, but you're also empowering clinicians to have the tools to know how to better care for patients.
And these are rooms full of multidisciplinary specialties. So it's not just the OB-GYNs, it's not just family. Because cardiologists, neurologists, pelvic floor physical therapists, all coming up and saying, thank you, thank you, thank you.
I just talked to somebody who's in menopause. She hasn't had a period in over a year. She's young. She had DOR years ago. None of this is surprising now. But she said, well, I asked my PCP who said my symptoms weren't bad enough and not to worry about it.
We have a lot of advocacy to do, education to do, and that's really like my bigger mission is we need to mandate this education, not just for OB-GYN. Like this should not be OB-GYN is busy enough, right? We are busy delivering babies, doing gynecologic care. That is a full-time job. Adding in all of women's health after reproduction ends is ridiculous to dump that in the OB-GYN's lap. This should be
it really needs to be carved out.
Clinician.
Just like fertility has too, though, right? But it's everybody's responsibility. If you see somebody and they want to say, well, I want to have a kid one day, to know some basics of what that conversation should be and at least feel like they can help a patient get started on that journey or get them to the right place, even if they're not. The answer is not, well, you should just keep trying, or, oh, those are just normal signs of aging. What are symptoms that women should be aware of?
So when we start in the perimenopause journey, like you had mentioned earlier, straw staging is one way to look at it, but I think it's a mistake to rely on the menstrual cycle. I think that's the last thing to go. Once your cycles become irregular, as you know, working in the fertility space, you are down to the very end of your egg supply. We can't do much then. Yeah. But women start noticing, I just don't feel like myself. It really is the mental health and the cognitive changes that happen first, because ovulation happens in the brain. It starts there with the hypothalamus. Estrogen levels get low. It sends signals from the hypothalamus to the pituitary. I'm speaking to the choir
I love it. I'm like, audience, you should know this.
And when those signals become disrupted and we're not getting the feedback from the ovaries that they're used to, the brain doesn't like it.
No, it really would like estrogen.
40% increase in mental health disorders across the menopause transition. We see increasing levels of depression and suicide, from untreated, from not recognizing the hormonal component to
this. And how important estrogen is for your brain.
Right. And progesterone's effects on the brain, very, very, very important. And so, for your listeners, what we see in perimenopause is, premenopause, roughly, and of course there's some variation, baseline estradiol levels produced in the ovary are about 50, okay? And then with ovulation, 150, maybe 200. In perimenopause, if you happen to draw a random level, you can see 12, you can see 600. I've seen the gamut up to 900 even. the signals become so chaotic, and the brain does not thrive in chaos. The cognitive symptoms and the mental health does tend to calm down once we flatten out and lose our estradiol. They're not great, but you know, where
like
we
stability.
see the first thing is always, I just don't feel like myself. Something's not right. My environment hasn't changed. You know, I haven't had a big life event, but I am losing my resilience.
And we should trust women. And I tell patients this all the time. Can you draw a test to see if I'm stressed? And I'm like, I don't need to, because I trust you. Like, you can tell me if you're stressed. You know, if you don't feel like yourself, if you're fatigued, if you don't have energy, like
You're not waking up rested.
yes, if everything hurts, if you have no libido, like, I believe you. We don't need to run a test to prove, well, that doesn't mean that tests aren't helpful, but I don't need a test to believe you. But so often women are not heard.
And we weren't trained to recognize that all of this constellation of symptoms could be related to her hormones.
You know, and I think a big piece of this is tied to inflammation, because we know estrogen is anti-inflammatory. And when this starts to go down, that becomes a stressor for the body as well. So then your stress hormones go up, in addition to all your brain sending out all that FSH it can to try to get more estrogen, but it's not coming. And we start to see this cycle of this inflammation wreaking havoc on the body as well.
So when I started researching for what became the Galveston diet, you know, I worked at a big university, and I took care of everybody. I delivered everybody's baby, all the PhDs, all the nurses, so I had some friends I had developed who were nutrition scientists. We actually had a really great geriatric nutrition department. They did a lot of work on protein, which is why I'm such a fan of protein. And so I called them up and I was like, hey, why is everyone complaining of the same thing? All my girlfriends, me, what is this weight gain? What's going on with the belly? You know, I was taught work out more, eat less. I'm doing those things and nothing is working. Like, and I had thin privilege most of my life. And all of a sudden I'm like looking at this, you know, pregnant looking belly, and I'm like, I'm not pregnant.
Something has changed.
Something has changed. And they said, there's something going on with inflammation and it's tied to estrogen. I'm like, what? No.
Another thing we weren't taught.
Yeah, I was like, what? First time in my life, okay, and I'm 48, and I hear that estrogen is related to inflammation. I thought estrogen would cause inflammation because it was bad, right?
Right.
They go, no. They send me down the rabbit hole, all these research articles, and I am losing my mind at that point. Like, no one taught me this. Why don't we know this? Like, chronic systemic inflammatory markers go up. Insulin resistance is going up. Your LDL goes up 19%.
You have heart attacks more when your estrogen is low too, even throughout a normal cycle.
So I was like, holy cow. Like, why isn't everyone screaming this from the rooftops? Why are we blaming patients for this? And that's began my journey.
What do you recommend that somebody starts to do if they are hearing some of this and they're like, okay, so I have inflammation and I don't feel like myself, and maybe I'm starting to enter into this perimenopause phase, but I don't know who to go to.
Right.
Or what to do. Where do we start?
So I wish I could tell you could just confidently march into your wonderful OB-GYN's office who delivered your babies and has done magnificent care, because I was her.
Yeah.
Okay. We weren't taught, we weren't trained. If she or he has chosen to step outside of their usual training and get Menopause Society certified, or, you know, I was self-taught initially, you know, that's great, but they're hard to find. So Menopause Society has a list of certified clinicians on their website. It's not perfect, but that is a place to start.
It's a good start.
We have compiled a list of testimonials from my beautiful followers. We have several hundred clinicians who they felt wonderful with, and they've written these beautiful
on your
testimonials
website?
on my website, and we have divided them by city and state and country. Even we have some in Canada, some in Europe. So that's another place. There's some great telemedicine options now. I think that is a wonderful way to fill this gap, where they're specifically trained to do menopause care. And there's 3 that I've kind of not vetted, but talked to their owners, looked at the protocols, think they're doing a great job. MIDI, Alloy, Evernow are wonderful, you know, options. There's some not great ones out there. So if I don't mention them, you know, they may be good, maybe bad. Just do your research. Talk to your friends. Do they have someone in your community who's doing it? It doesn't have to be an OB-GYN. It could be family medicine, internal medicine, really anyone. It doesn't have to be an MD. There's some incredible nurse practitioners and PAs out there who are doing wonderful menopause care.
It's really about somebody who is passionate about it, will listen to you and personalize treatment, right? And who's staying up to date on latest research.
Yes. and hard to do. When your medical organizations haven't changed ACOG is not, American College of OBGYN has not changed the menopause guidelines in 14 years.
Well, I have a lot to think about ACOG. I mean, when it comes to fertility, they say that there's no reason to even screen for, your egg count in somebody who's not actively having infertility, because it's not going to provide helpful information and it might stress you out. So
we just now there was a big meeting in Europe, and we have a group chat we call the menopause.
I love it.
And so they're worldwide. And so we have a lot of clinicians in Europe and Asia and different places. And so we're always like, what's going on in your country? So there's this big Andropause and Menopause Society meeting in Europe. So they were saying, Martha Hickey from Australia, who kind of runs their Menopause Society there, got up and said, we are scaring women. Talking about the suicide rates during perimenopause is scaring women, and we should not be doing that.
So we should stop talking about it.
Right, because we're putting ideas in their head. I'm like, excuse me? When did we infantilize our patients?
Oh, my God.
Like, this is who is, like, this is the old school, old guard.
But that's who's in charge of societies. I mean, like ASRM, Menopause Society, ACOG. I mean, we see that there's an old guard who feels like patients can't see data and hear risk-benefit or make a decision.
Right. And they don't trust women to make good decisions for themselves. And I think that's a mistake.
I think so, too. Good segue into HRT. So why don't we explain a little bit about HRT and your approach to it to somebody who might be thinking, can hormone replacement help me?
So there's many words, many titles, hormone replacement therapy, hormone therapy, menopause hormone therapy. So hormone therapy is just giving you hormones. That could be thyroid hormone. That could be,
I love that take. Because we give hormones all the time.
People
don't think twice about taking thyroid
therapy.
hormone.
That's hormone therapy. Anytime you put a hormone in your body that you didn't make naturally, that is hormone therapy for whatever reason you need to use it. Okay. Specifically for menopause, we have MHT, which is menopause hormone therapy. And for the new menopause, that is the term I kind of use to differentiate. Birth control pills are hormone therapy.
Right.
So for menopause hormone therapy, we have 3 buckets of hormones that are, our sex hormones. So we have estrogens, we have androgens like testosterone, and we have progestogens, okay? So specifically amongst the people that I've learned the most from, trust the most, the number one product we're trying to give a woman back is what her ovaries used to make, which is estradiol.
Right. Replacement in a way.
Replacement, right? And so we are replacing what she used to make, or we are supporting what she's struggling to make. So in perimenopause. And usually we're trying to use estradiol to do that. Now, in a birth control pill, we use something called ethinyl estradiol, which is not estradiol.
It is not. Doesn't even show up on an estradiol blood test.
No. So like if I have a patient who comes in on birth control pills, for whatever reason, she needs it for contraception, and I happen to accidentally draw an estradiol, it is 0.
Hold on. I will get sent patients all the time because they will have hormones drawn on birth control pills by their OBGYN who's trying to help them, and they have an FSH, LH, and an estradiol drawn while they're on the pill, and they're all between 0 to 1, and they get sent to me with this like hypoestrogenic, hypothalamic amenorrhea whole thing. I'm like, you're just on the birth control
You're on birth control pills. And so ethinyl estradiol is 300 times more bioactive than estradiol. It does bind to the similar receptors, but it doesn't exactly do the same thing. And so in perimenopause, I have options to either use a birth control pill, like if she needs contraception or having heavy bleeding, if there are symptoms that I'm trying to manage and control, sometimes birth control
the pill is the best
would be a good option for her. Or, if she's not having a regular bleeding, if her husband's had a vasectomy, she's got an IUD, I may go straight to estradiol. So options there. In the progestogen world, we have progesterone, which is what our ovaries make, and then we have about 9,000 synthetic progestins, okay?
And they all make you feel very different.
Right. And they work very differently. I love having options. Progesterone's not the best thing for everyone. Some people don't tolerate it very well, but it is my go-to. So you asked for my go-to. Estradiol, oral micronized progesterone. And then for androgens, I'm doing straight up testosterone.
As the testosterone that a man would be prescribed.
Exactly. I actually borrow my husband's,
do a little squirt.
I say a joke. He actually has plenty of testosterone. His levels are fine. But I borrow the men's version to treat my female patients. We just have to do a microdose because it's so concentrated. They don't make one for women. So my option is compound it. My patients travel quite far to see me, and I don't know every compounding pharmacy in Texas. Right. So I'm going to go with the FDA-approved option.
It's FDA-approved, right? We know that it's safe on certain levels. Even if it's not FDA-approved for women, it's been through some validation.
Right.
And that's always better than maybe not knowing exactly.
But my go-to is not compounding. Right. I like having it as an option. Not everyone fits in the box. But, I just want your listeners, anyone watching to understand, you do not have to have compounding to have a safe, efficacious, and bioidentical hormone therapy. All of that can be provided from CVS.
I think that's a really important point, because sometimes we go down the rabbit hole and we think that if it's not this one thing that this one person is on or said, that it's not good. And what I'm hearing from you is that really this is something that should be personalized.
Exactly. Individualized.
Not a one size fits all.
Right.
It really depends on the stage of life you're in, your goals, because estrogen replacement alone is not contraception. And we know this because young women who go into premature ovarian failure, when we put them on estrogen, and we usually cycle them with some progesterone, they will start to ovulate again. It'll be very sporadic and very random, but that estrogen will lower their FSH. And if they have just a few eggs hanging out, they can have a random ovulation. And I've had patients get pregnant after years on estrogen therapy if they went into ovarian failure in their 20s.
Yeah.
So I say, hey, this doesn't mean for sure that this is a contraceptive option, especially if we're talking about this perimenopause time frame where we know that women still do have eggs. And even if pregnancy is less likely, it's not a zero thing. And we should have good, reliable contraception if that's the option.
If she needs it, yeah.
If she needs it. What do you think about non-hormonal strategies? So obviously, I think that sometimes maybe
you
hormones
have patients
aren't right.
who have contraindications. They have a tumor being fed. They, they're in the middle of a workup for a stroke. They're in the middle of a workup for a DVT. They're not a great candidate. They have undiagnosed vaginal bleeding. And what do you do? Right. Unfortunately for those patients, estrogen is wonderful because it binds to all these receptors all over the body. Right. I can decrease her risk of cardiovascular disease. I can decrease her risk of colon cancer. I can decrease her risk of osteoporosis by 50%. Nothing else does that all in one efficient way. So I have to treat her hot flashes separately. I have to treat her, musculoskeletal pain separately. I have to decrease her risk of cardiovascular disease with lifestyle options, with statins, whatever we need to do. And so, it's a very piecemeal version if she's not a candidate, but there's no supplement that is going to grow your eggs back. There's nothing
we would give it to
works
you.
Better than estradiol. Trust me, I would have it on the market right now. Yeah. So, but that is the best thing. But there are patients who don't want it, totally fine, or aren't good candidates. And so we have to really piecemeal their care from there.
I see this sometimes where somebody comes into me and they say, I just don't believe in that, or I don't want that, before they've heard about it. And often we're talking about IVF, or maybe we're talking about hormone replacement. Well, I know my period's not here, but I do not want to be on estrogen, or I do not want to be on the birth control pill. And I always say, you get to choose what's right for you. But my plea is that you make the choice after you've learned.
Based on facts and not fear.
So instead of just saying, I heard this, or I read this, or somebody told me this, we learn about the options. And maybe what you're saying is absolutely the same conviction you'll have afterward. But very often, once women really step back, if they hear and they're presented choices, they'll actually make a choice they thought they never would, because that was based in fear.
And misinformation, misguidance, someone trying to drive you towards one option, and not give you the menu of options and let you make a decision for yourself. I have a huge problem with that.
I think it's important to think too, we're talking about personalizing, your medical treatment, talking about if you can't have hormonal options. One thing I always tell my patients and listeners in general is that take the time to really think through your story, because the first thing your clinician is going to ask you is, well, what's going on? And there's no reason for you not to be prepared for that, right? In the new menopause, you've got a whole list, it's like pages long, of all the different symptoms that are going on. And you can look at them and mark and think about, how long have you felt this way? What all is happening? And especially if you're trying to piecemeal together an approach to somebody, because maybe they can't have estrogen. You want to know, well, what's impacting their life the most, right? What's the priority? What do we need to fix first or try the hardest for?
In our clinic, I talk about putting out the fires of menopause. Like, they're coming in and they are not functional. They are lost their resilience. They're struggling. They're not sleeping. Like they're waving every flag in the world. So we get that taken care of. We get that calmed down. And then we start talking about the diseases that plague their elders. how did your mom age? What about your grandmother? What about your aunts? You know, what are the diseases that destroy their quality of life? And so sadly, for most of my patients, the end of life for the women in their family is not great.
Right.
And that's what
Hip
we
fracture,
see throughout
immobile.
the population is not this grandma who kicked it until 95 and was cooking and hanging out and, you know, she slowed down a little bit, but, you know, no, we're talking nursing home admissions, who's going to take care of grandma, fights amongst the, you know, my patients are like, absolutely not. I don't want to do this to my children.
Right.
Who's going to take care of me when I get old? We don't worry about that with our dad. Now, not all men, of course, you know, but like
We don't think about dad that way.
men tend to live and have a very short loss of independence and die quickly, okay? Women do the opposite. They live and have a protracted loss of independence, which is and they don't want to be a burden on their family. So, you know, once we take care of the menopause, you know, then we're looking at what lifestyle things do we need to take a look at. How are we going to age healthily? How are we going to maintain our strength and our resilience and decrease our risk of cognitive decline?
Well, this is a great segue into what lifestyle factors do you recommend? Because I'm big on helping people take charge of the factors they can control.
Right.
Because not everything's in your control, but you make a lot of choices every single day, which are in your control. And you're setting the foundation for your health by some of these choices. So what do you recommend when it comes to exercise and protein? I know you have...
So we look at, so in my clinic, we have a body scanner.
Love it.
So I can look at her visceral fat level, which is going to tell me her risk of chronic disease, right? Because elevated levels of visceral fat increase your risk of diabetes, hypertension, stroke, you know, 7 of the top 10 causes of death. We also look at muscle mass. Muscle mass is going to determine her risk of insulin resistance, frailty, loss of independence due to not being able to move. You know, the things that scare my patients that I can't think and I can't move as I get older. And so...
And that's huge. I mean, we got to say that again,
It turns out
right?
that those foundational health things kind of work for everything. So it's not like you want to do this kind of exercise for your cardiovascular disease risk or this kind of exercise to decrease your dementia. It all works the same. You know, the healthier you are, those foundational things. So we look at protein intake, we look at fruits and veggie intake, we look at exercise, both cardiovascular and resistance training. Most of my patients walk. And that's most of the exercise they do. We have a whole generation of women who have dieted their way into frailty.
Well, that's what we were told too, was you should be
I was thin. I'm healthy.
Cardio is the exercise that you should be doing to protect your heart. And there was no emphasis on building muscle and how it can help improve your insulin resistance and your inflammation and your longevity.
It was like that side of the gym was for men.
Right.
You know?
We hung out on the treadmills.
Yeah. Treadmills or an aerobics class. Actually, I loved step aerobics. Back in the day.
I did it in med school.
It was super fun.
At UTMB, there was always a step aerobics class we would go to, and it was my favorite.
Yeah. That was community. You know, my girlfriends now, it's like a Zumba class, but they're all picking up weights, and they're going in with their weighted vest.
With the weighted vest on?
Yeah.
I feel like you've started the weighted vest movement.
You know, that all started because I have patients coming in who can't take HRT, and I'm like, what can we do for them? What do we know? You know, I'm following Vonda Wright, I'm following, you know, Kelly Casperson, and I'm like, wait a minute. There were studies done on like these sweet little old ladies in nursing homes who had lost their independence, who were frail, and they put weighted vests on them, and they saw improvements in their bone density and their muscle strength and their ability, you know, their ability to take care of themselves. I'm like, well, if it happens for them at 75 and 80, what if we started wearing it at 50?
Right.
You know, I want to prevent this. I don't want to get to that if I can help it. So all these things that are working for the treatment of osteoporosis and frailty,
can we prevent it?
Can we use them to prevent? And so I ordered myself a weighted vest on Amazon and started wearing it on videos, and all of a sudden, I'm the godmother of the weighted vest.
I have one.
Like, I brought mine here to Austin, so we're gonna go walk in tomorrow morning.
I love it.
So yeah,
I think that's, you know, I'm hearing you say that we don't need to just cardio our way. Not that cardiac activity is not important, but there's this whole other aspect, the whole other side of the gym, that building strength is
balance.
Really,
So
mobility.
So the yoga, the Pilates, but like just, you know, are you maintaining your muscle mass?
Right.
And you can go and get a DEXA scan. You know, what is your baseline bone density? That's another thing. You know, just had a huge Instagram live with Christy DeSapri. She does women's bone and body. I mean, she's the osteoporosis queen. And she talks about 65, cows out the barn.
Right.
You know, for bone density. Like I'm telling every woman who will listen to me, and if I can afford it, and I have to lead the room, you know, getting a bone density.
My PCP orders it on everybody who's 40, every woman who's 40.
And
I love
brilliant.
that, right? She's just so ahead of the game.
Yeah.
And she's like, you know, if it's low, then we'll have more room. But also, like, why? Is there something else going on?
I'm like, do not let an insurance company dictate your health.
I mean, at the end of the day, I mean, there is some privilege to it, but we have choices now when it comes to getting some of these tests done, and it's your only body. We have to take care of it.
Right.
What about nutrition? Nutrition, I know you have a big focus on decreasing inflammation. You and I are both very passionate about this.
Mediterranean diet, Galveston diet is similar in many ways to Mediterranean diet, but really increasing the amount of whole grains, fruits and veggies, nuts and seeds, legumes, which are beans, peanuts, you know. And there, you know, I learned this from Zoe, so I totally stole this from them. But the 30 plants a week challenge. So I run these challenges for fun on social media. And one of the things is try to get 30 different plants in your diet per week. And I have a little checklist and I write down, you know, all the things. And it turns out when you do that, you're getting high fiber, you're getting anthocyanins, you're getting, you know, we always say eat the rainbow. Try to put as many colors on your plate as possible. Because when you vary your diet that greatly and fill it with plants.
Lots of nutrients, lots of vitamins.
You check all the boxes of nutrition. It just happens naturally. So, you know, my patients on GLP-1s, I'm like, protein and plants. That is your goal. You know, and really limiting the ultra processed, the convenience foods. You know, we all get in a rush, we all get in a bind, but those foods are not healthy for you by and large.
They're not made for your body.
Right.
They are not processed the same
They're
by your
easy,
digestive tract.
They're less expensive, but like that should be, you know, few and far between, really.
You and I have a mutual love of fiber and its impact on gut health and decreasing inflammation. Do you kind of want to explain what fiber does and why it's so helpful?
So there's soluble and insoluble fiber. So fiber is a natural thing in plants, and we can't get it from, you know, from meat. It doesn't come from that. And fiber is what makes things crunchy, what gives it structure, and it does a whole lot in our gut, a lot more than we realized. And women who have naturally high fiber diets, like 35 to 45 grams, have way lower cardiovascular disease. That is why the vegans and vegetarians tend to have better, we think, you know, many things, but they have better cardiovascular disease rates as their diets are so naturally high in fiber. And so fiber will pull water into the gut and move things along quicker through the, you know, so you don't have things sitting in the colon for a lot longer. It will bulk up the stool in a positive way as long as you drink the water. Don't eat a lot of fiber and not drink water. That is not, you're not going to be happy with what happens.
No.
And so you must hydrate if you're going to have that much fiber. And fiber, the soluble fiber is the food for our gut microbiome.
Yes.
So we were talking about, I laugh so hard when I see, contains prebiotics. That is a smidge in a prebiotic pill. You know, you need like a bucket of fiber. It is like...
It's hilarious in a way.
So, you know, our company sells a fiber supplement, but that, I tell my patients all the time, this is a helper. This is not your main source of fiber. Most of your fiber should come from food. This is just to help you get over the edge, you know, to give you a little bit of a boost. But our fiber contains soluble and insoluble components.
I know, because that gut microbiome, it helps you metabolize estrogen. It's so important in inflammation control.
Right, and the estrobolome.
Yes.
So how we...
Which is...
We circulate estrogen through the gut.
So this idea that I'll just take this pill for it and not focus on these other aspects of my life too really is a false idea in my brain, right? Anything that maybe there is medication replacement that you do need and can be helpful. So taking estrogen, there's nothing that will compare to that. If you're a candidate for estrogen and you're in menopause, in my opinion, nothing will do what estrogen will do for you. But there's other aspects of your life that you should not ignore.
That, it's not a miracle.
Toolkit, I forgot.
It will stop your hot flashes. But I think as far as health span, if you're not addressing all the core pillars of health, your stress, your sleep, your nutrition, your movement, it's likely not going to give you that much of an edge in your health span, estrogen alone.
All right. Well, we could talk all day, but we're going to wrap it up. And I'd love for you to say, you know, one key takeaway, one key piece of advice that you would like to give the audience when it comes to this midlife transition or how to advocate for themselves.
Educate yourself, because you might know more than your provider. We've done a terrible job as a healthcare system worldwide. I have friends across the world really preparing women for this and having them understand what's happening. You do not have to suffer, but you must be the CEO of your own healthcare.
I love that. The CEO of your own healthcare. Well, Dr. Haver, thank you for being here. Will you tell everybody where they can find you and follow you and buy the books and all the exciting things?
Across social media channels, it's Dr. Mary Claire. And the book is The New Menopause, available everywhere you buy books. The New Perimenopause,
which
will
we're
be
excited
coming
about.
out. It's a year away. But I'm deep in the research and writing those chapters right now. And it's just so inspiring. And I'm so happy about it.
Okay. Well, I can't wait for it to come out. We can have you back and we can show the new book off when it does. And thank you guys so much for listening to this week's episode of the As a Woman podcast. And until next week, thank you, friends. Thank you for listening to the As a Woman podcast. If you're ready to take control of your reproductive health, my new book, The Fertility Formula, is your next step. It's a science-backed guide to understanding your hormones, optimizing your fertility, and owning your reproductive future. You can order your copy and learn more at nataliecrawfordmd.com/book. And as always, follow along at Natalie Crawford MD for even more support. Because knowledge is power, and your health deserves a formula made just for you as a woman.